So, HCV is a small single-stranded RNA virus of the flavivirus family, the same family where yellow fever, Zika, and dengue virus belong. Can cause both acute and chronic liver disease, just like HBV. The infection is usually insidious, and most patients are asymptomatic or suffering from only a mild disease. However, compared with HBV, it has a greater tendency to produce a chronic infection, and infection is acquired in adolescent and adult life, as compared with HBV, in which about 20% only go on to develop chronicity. About 55 to 85% of patients with HCV develop chronic liver disease, out of which 10 to 20% will develop cirrhosis, and a further 10% will develop hepatocellular carcinoma after about 10 to 20 years. Talking about prevalence, as of 2015, it was said to be around 71 million worldwide, and it remains one of the main causes of chronic liver disease worldwide. And it's important to note that there are about 6 genotypes, and which genotype 1 and 3 are the most common cause of infection. Other genotypes include 2, 4, 6, 5, and others. Talking about natural history of the disease, infection is acquired through a percutaneous exposure from injection from blood transfusion, sexual practices, infected shafts, among others. While as I said earlier, most infections are asymptomatic, whereas chronicity develops in about 85%, and 25% of chronically infected patients develop cirrhosis. Risk factors for cirrhosis include male sex, obesity, alcohol use, and marijuana use. Talking about the progression, it can progress from stages where the fibroids are just not there or minimal, to from F4 when you have severe cirrhosis, F4 called ABC, and later to hepatocellular carcinoma. Infection occurs worldwide. Estimated about 21 people are chronically infected. The regions where you have the highest prevalence include Africa, especially Egypt. Egypt is said to have the highest prevalence worldwide. Also Central and East Africa, including Japan and China. In a study done in 2018 shows that HCV seroprevalence around 1.1%, with estimated population of 200 million. It shows that about 2.2 million Nigerians have chronic HCV infections. Route of transmission include from unscreened blood or blood products, injection from quacks, transmitter practices like body piercing, tattooing, scarification, sex, which is actually a low risk, personal sharing of personal items like toothbrush. Vertical transmission is not as effective as what you have in HPV, but high risk for vertical transmission is when the HCV RNA in the mother is very high late in pregnancy. It's of note that there's no immunity after the restriction of the infection. There's no vaccine for HCV. Also, there are some subdivision of the genotype 1A and 1B, and there are different genotypes from one region to the other. This is just a chart that shows different practices and the risk of transmission. Who do we screen for HCV? Anybody that is hepatitis service antigen positive, HIV positive individual, blood donors, people that inject drugs, or children born to HCV infected mothers, pregnant women, healthcare personnel, very important, including emergency care workers, people who have classification marks, injection from squads, commercial health workers, people who has partner that is HCV infected, men who have sex with men, but who transfuse patient that sickle cell anemia patient on hemodialysis, patient with CLD or elevated liver enzymes, prospective organ donor, prisoners or previously incarcerated patients. This is just a slide that shows that HCV is not just a liver issue. There are extrahepatic manifestation from hematological to dermatology to renal to endocrine, ocular, vascular, amongst other. Investigation, you want to do first antibody to HCV using a third generation ELISA, and after that, you want to do HCV RNA, which is a quantitative assay that is required to make diagnosis. So when you have antibody to HCV with a positive HCV RNA, it is actually diagnostic of HCV infection. But if another thing we can do with HCV core antigen, which is also a marker of HCV replication, that may be used instead of HCV RNA to diagnose acute or chronic HCV infections. HCV genotyping can also be done for this patient. Features that could suggest acute hepatitis includes when there's a seroconversion to HCV antibodies in individual previously known to be HCV negative. That could suggest acute infection. HCV, anti-HCV negative, but HCV RNA positive. That could also suggest positive infection. But patient is anti-HCV positive following recent surgical or dental or tradomedical procedure. Other investigation to do for patient that is HCV positive include want to do HB panel, because as you know that both can be acquired through the same means. Want to test for other hepatitis viruses like hepatitis A, want to do retroviral, full blood count to do the platelet count. It's very important to calculate the HAPI score. Liver function test is important, and also want to do advanced fibrosis screening for this patient using different fibro score to check for fibrosis. Also serum creatinine. You want to do pre-treatment evaluation, markers of autoimmune disease, thyroid function test, iron saturation test, pregnancy test for female, assess and counseling in case of alcohol or drug abuse, then assess for depression or psychiatric illness. This is the HAPI score, which is if it's more than aspartate aminotransferase to platelet ratio index, that's the HAPI score. Value more than 2 is the high probability for schema fibrosis. Other fibrosis score include the first score, fibro test, fibro scan. Fibro scans are an ultrasound device that can be used to assess early fibrosis. All these are non-invasive means of checking for fibrosis. The goal of therapy is to cure HIV in order to decrease viral replication, eradicate CV, prevent complications, decrease frequency of hepatocellular carcinoma, improve quality of life, remove stigma, prevent onward transmission of HCV through treatment and prevention. We should be treated all patients who are HCV RNA positive or HB core antigen positive. Acute hepatitis C after 12 weeks of observation with no foreign HCV RNA titer. So, conduction to treatment, most of these complications are actually relative because of the advent of the direct active antivirals. These are majorly during the time of when we use ribavirin and interferon. As I've mentioned, in the era of direct acting oral antiviral agent, most of the above conduct can be treated. Then patients that use other medications that are cytochrome P450 inducing, because most of the DA work with the cytochrome P450 drugs like carbamazepine, phenobarbital, drugs that have been used, standard interferon, pegylated interferon, ribavirin. Then we have now what's being used mainly now the direct active antiviral, which are actually categorized in the first generation like Feripreva, Multipreva, second generation Sumipreva, Paritrapreva, Gasopreva, HCV polymerase inhibitor like Soposbuva, Dasabuva, HCV NS5A inhibitor like Daclasava, Lepipasva, and Umitasva. The side effect of interferons are flu-like symptoms. Ribavirin also used in the past. Adult dosage is there with the side effects. Patients that are on treatment should be monitored. Quantitative monitoring of HBV viral load is recommended after 4 weeks on therapy and at 12 weeks and 24 weeks. For those with detectable HBV RNA at 4 weeks, repeat testing in 2 weeks is recommended. If HBV RNA levels increase by more than 1 log unit, therapy should be discontinued and check for resistance. Sustained viral response is the term that is used to check for response and defined as undetectable HBV RNA 12 weeks after completing therapy. If HBV RNA becomes detectable again after sustained viral response, the patient is considered to have relapse. This is a table that shows the different genotypes of HCV, 1, 2, and 3, 4, 5, and 6, and different direct active antiviral that can be used in those genotypes, and also the duration of treatment. For patient that has compensated cirrhosis, these are the drugs that are recommended for them based on the genotype, and it's of note that they will have a longer treatment duration as compared with those one that doesn't have cirrhosis. The current standard of care is to use all oral DA, some of which are effective in all genotypes. We call them pan-genotypic oral DA. The pan-genotypic option is to remember is the Soposbuva and Velpatasvir for 12 weeks in patients without cirrhosis, and either for 24 weeks alone or combined with pregabalin for 12 weeks in those with compensated cirrhosis. If Velpatasvir is not available or not available, then sofosbuvir and daclazone will be used. The pan-genotypic HCV regimen can be used to treat individuals without identifying their HCV genotype. Triple combination of sofosbuvir, Velpatasvir, and zolpidem is recommended for resistant cases of genotype 1 through 6 who have failed treatment with NS5 inhibitors, or genotype 1A or 3 who failed treatment with sofosbuvir without NS5 inhibitor. The treatment of resistant cases, however, should be reserved for the hepatologist. The combination of sofosbuvir and ledaspivir for 12 weeks can be used in genotype 1, 4, 5, and 6, and should only be used as alternative in genotypes 2 and 3 when the preferred regimens are not available. Combination of vegetable interferons, pregabalin and sofosbuvir, though initially favored, is no longer widely used as the DAA are now readily available in Nigeria. So DAA are now the preferred drug of choice because of their virologic efficacy, easy of use, safety, and tolerability. Patients with decompensated cirrhosis should be treated urgently with DAAs. In regions where liver transplant is available, patients should also be placed on transplant list while waiting for liver transplant and post-transplantation to minimize possibility of a lapse and allograft. Patients with HCC without cirrhosis or with compensated cirrhosis, that is type A, awaiting liver transplant should be treated for their HCV infections prior to or after transplantation, according to the general recommendations. Those who are eligible for potential HCC curative therapy with liver resections or ablation should divert DAA therapy until HCC treatment is completed. For all oral therapy, HCV RNA should be done at baseline and at 12 weeks or 24 weeks. 12 weeks says we are 12, 24 weeks says we are 24 post-therapy. At the concordance is more than 89%. HCV RNA testing will be done at the end of treatment, but it is not mandatory. Undetectable HCV core antigen, the serum or plasma, 12 weeks or 24 weeks after the end of treatment can be used as an alternative endpoint of therapy in patients with detectable HCV core antigen before treatment. In patients with advanced fibrosis, that's metaverse score of F3 and cirrhosis, there should be continuous surveillance with 6 monthly fetal protein test and ultrasound scan for HCC because the attaining SVR will not abolish the risk of HCC. Also important for those with cirrhosis to do endoscopic screening for severe varices. Monthly hematological and biochemical profile should be carried out. In treatment of DAA failure, therapy is guided either by knowledge of treatment causes previously administered, or if resistant test is available, the likelihood of the response according to the resistance profile. HCV infection should be suspected in case of reappearance of HCV RNA or HCV core antigen after SVR in an individual with risk factors for infections, and confirmed with demonstration that infection is caused by a different genotype or a distantly related strain of the same genotype. How do we prevent? Prevention is very important. Hello?
It should be rounding up.
Okay, prevention. Currently, there's no vaccine available for HCV infection. The following preventive measures are, however, advisable: screening all potential blood and organ donors, sterilizing of equipment and tools for surgical and invasive procedures, use of disposable syringe and needles, public health enlightenment campaign, observance of universal precaution in the care of high-risk patients, dialysis patients, syringe and needle exchange program where people with injection drug can access these services, treatment of infected patients to reduce the survival of infection in the community. These are my references, and special thanks to Dr. Kelly and Dr. Briggs for the materials. Thank you very much.
Thank you so much, Dr. Akimu, for that beautiful presentation. Very detailed and lucid. Thanks so much. So now we'll take comments and questions from the participants first, and let's keep the thanks coming on the chat. And if you would like to make a comment, you can raise your electronic hand. Okay, there's a hand up already. Okay, Chief Justice, please go ahead.
Okay, good morning, teachers and colleagues. Thank you very much for a very lucid presentation. I just want to add just a few things. One, you talked about the fact that the contraindications to treatment, and then your statement was that because we now use the DAAs, there is no longer contraindication. No, really, for pregnancy specifically, we still don't really jump into treating them with the DAAs. We don't have a lot of studies to confirm safety in pregnancy. And bearing in mind that HCV has a slow progression, so they can actually wait till after delivery before you even breastfeed before you start commencing treatment. However, you must evaluate properly to be sure there's no ongoing liver disease. The other thing I like to also add is post-exposure prophylaxis. You already mentioned that there's no vaccine for HPV, which is very correct. So I don't know if they can want to create a scenario of a health worker that probably got exposed, because these are things that we face from time to time. Probably got a needle stick injury. It's important to note that the risk of transmission via needle stick is also, even though yes, it's one of the common things, not exactly that high, it's about 0 to 2%, give or take. For mucosal exposure is about 0%. It's actually very low. But what we'll do, just like you would imagine, is to test the patient, that's the soft patient, as it were. These are going to American Association for Study of Liver Disease. If it's negative, or if it's positive, you want to do a viral load. If his viral load is high, that nucleic acid test is high, then you want to now test, you send the person for more specialized care. Then the recipient or the victim, as it were, is tested. If it's immediately, if it's negative, you do another test in about 3 to 6 weeks. If it's still negative, that's by negative, I mean serology. If it's negative, you could do another test in about 3 to 6 months. But if it's positive, you want to do a viral load. Viral load is still negative, you do another test in 3 to 6 months. If it is positive, commence test. If it's negative, then they can discharge. No further care is needed. Then another thing I want to mention is it's always very important to note that even when you have cured this patient that has HCV positive, the liver, the extent of damage that has occurred in liver is also very important, because if there were already some cirrhotic changes, the person still maintains the risk of progression to cirrhosis and then malignancy afterwards. So it's important to let them know that the fact that the HCV has been cured doesn't necessarily mean there was no damage already done to the liver during the period. And then you already mentioned again that it doesn't pose immunity. But one thing that they should know is that even after cure, the anti-HCV serology will likely still be positive for a very long time, and this should not be taken as a reinfection. However, a reinfection could occur, which means they should also live a very safe and healthy life afterwards to try to prevent further risk of reinfection. And then maybe periodically also do evaluation. I'll stop for now. Thank you very much.
Wow, thank you so much, Dr. Justice, for that add-on. Very beautiful. Okay, so Chief, you just take notes. Okay, so there's a question on the chat for you, and a lot of applause. Dr. Nelum is saying thank you, Dr. Rita Lacol, Dr. Becky. They also, Dr. Florence, excellent presentation. Thanks so much for the presentation. So Dr. Ade is saying thank you, Chief. Is sofosbuvir not pan-genotypic? How is it given, please, and duration of treatment in cirrhosis and non-cirrhosis? Okay, Dr. Joe.
Yes,
hello,
thank you.
okay,
Yes, I can hear you. Yeah, sofosbuvir is pan-genotypic. Is one of the drugs that I mentioned that are pan-genotypic, and that I mentioned are pan-genotypic, and it can be given. Okay, so like I mentioned, sofosbuvir and lepesvir for 12 weeks can be used in genotypes 1, 4, 5, and 6, and should only be used as alternative in genotype 2 and 3. It's one of the drugs that can be used in many of the genotypes and is given for 12 weeks. But for patients that have cirrhosis, you want to give for 24 weeks.
Okay, so sorry, let me just add. We don't really commonly give sofosbuvir alone. We commonly give, it's a combination usually, that we're giving sofosbuvir velpatasvir, or sofosbuvir daclatasvir, or sofosbuvir velpatasvir voxilaprevir. We usually give them in combination. And yes, just like you have mentioned, commonly we give at 12 weeks for non-cirrhosis and then usually longer. However, in some cases, we just give the soft vel for 12 weeks and it covers. Thank you.
Thank you very much, Dr.
Dr. Justice, thank you so much, Dr. Justice. Okay, so Dr. Mustafa Mohammed is saying, thank you, Dr. Joe, for the presentation. Any differentials?
For HCV,
Yes.
but the differential would be to, maybe check, maybe patient presenting with jaundice or signs of liver failure is to do a complete viral profile, HBV, HCV, and also some other viruses. So by the time you do those profiles, we're able to know which one is actually the one we are dealing with. I don't know if
All
I'm
right,
able to
thank you.
answer the question. Yes.
Okay. Did you mention hepatitis B?
Yes, E, yes, A, B, C, D, E, yes.
Okay. Okay. Thank you. Okay, so others are just applauding you, Dr. Bifiri says, excellent, Chief Ojo. Dr. Mamodo says, thanks so much. Okay, so I don't know if we still have more comments. I can't see any other hands raised. So I'll hand over to our teachers. Mark Christabel.
Well, thank you so much. Thank you, Dr. Kalai, Dr. Ojo, thank you. Thank you so much. That was wonderful. Dr. Justice, thank you for coming in. Thank you so much. I don't know if any of our teachers have any comment to add. Chief Kukima, any comment?
Just Dr. Justice hand is up.
I suspect an owner. It was one that spoke earlier.
Oh, okay. So anyway, I would think that the way to answer the question about differentials is to look at the way it presents. You know, you can present differently. You can present with extrahepatic manifestations and present with hepatic manifestations. So if it's hepatic manifestations, yes, other viral hepatitis can be considered, but even other conditions like autoimmune hepatitis, any cause of CLD can be considered as a differential. Or if we present with renal disease, so other causes of glomerulonephritis too can be considered. So it usually depends on how it presents actually. I think that's the answer to that question. Thank you.
Thank you, Chief. Thank you, sir.
Thank you. I don't need any more comments. Thank you so much. Okay. Dr.
Thank you.
Ojo,
Good
thank you.
morning, everyone.
Good morning, ma'am.
Yeah, so thank you to Dr. Ojo for the lucid presentation. So hepatitis C is really a broad topic, and being that it's not as prevalent as hepatitis B in our environment, so many people may not really know how to manage the infection. However, it is equally as dangerous in the sense that it can lead to end-stage liver disease, liver cirrhosis, and also hepatocellular carcinoma, all of which can lead to death. So just as he has said, introducing it, defining it an RNA virus, and then the mode of transmission, and the risk factors which it can be gotten. Also, all that suffices for the hepatitis C. Now, in the management for hepatitis C, it's much different. Or even when you are evaluating these patients, you need the screening tests and then other ancillary investigations to do. So if you notice for hepatitis B, we are checking for the surface antigen. And once it's positive, that tells you that the patient has the infection. But for hepatitis C, we are not checking for the antigen. It's the antibody. So anybody that has been exposed to the virus the antibody will be positive. So that's why for you to treat a patient for hepatitis C, you must check for the viral load. And then we're not looking for qualitative, we're looking for the quantitative viral load. And the management of hepatitis C in the past had to do with the genotypes, which are 6 in number. But because of the advent of the pangenotypic therapies, we no longer so much dwell on the genotypes, except the patient fails treatment. So in evaluating these patients, you must confirm that they have hepatitis C by doing the viral load, the HCV RNA. And then you need to check for other co-infections. So you need to rule out the other hepatitis viruses and as well as HIV, because all this matter in the management of the patient. And then you do further evaluation to stage the degree of liver fibrosis of this patient. So you do your liver function test, the full blood counts, the clotting profile. You also do an imaging of this patient, and then either the invasive or non-invasive test for liver fibrosis. So the scoring systems he mentioned, and then liver biopsy, which can also be done, but because they are non-invasive methods, we tend to go for that. And then the fibroscan, which has been validated a lot for hepatitis C infection. So the management of the patient depends on 3 parameters. One, is this patient treatment naive, meaning that this patient has never been treated before, or does this patient have cirrhosis? And then if this patient has cirrhosis, is it compensated cirrhosis or decompensated cirrhosis? So you must answer these questions, because it now tells us for how long we're going to treat this patient. Now, if a patient is treatment naive, it's a good thing, and then the patient is non-cirrhotic. So these are the patients that we usually treat for 12 weeks. And you must have done all these, the pre-evaluation tests, to know the before treatment and then hereafter. And then to know them, because it is a curable viral infection, about 90 to 95% of cases, that's when you're talking about, especially if the patient is pre-cirrhotic, then you would. So what we use in assessing treatment where this patient has achieved treatment is the sustained virological response. And that is the absence of the HCV RNA 24 weeks after completion of treatment. So you can have the early, which you can check 4 weeks after, or you can have the mid, which is SVRO 12 weeks. But usually the treatment goal is 24 weeks after completion of treatment. So for those who are naive and who are compensated cirrhotics, we usually treat for 12 weeks. Now, those who have treatment failure or are decompensated, you have to treat for longer, and we usually treat for 24 weeks. Now, usually we'll give ribavirin in those who are treatment experienced, who have failed treatment, or who have decompensated cirrhosis. You do not give interferon, pegylated interferon, in decompensated cirrhosis. It's contraindicated. And then if you are going to use interferon, pegylated interferon, 2-alpha, you need to rule out a number of things, because it's known to precipitate psychiatric disorders. It's known to also, because of its mechanism of action, is an immune modulator. So you have to screen for tuberculosis, you have to screen for underlying thyroid abnormalities, and alcohol or drug abuse, because of its tendency to potentiate psychiatric disorder. And it cannot be given in pregnancy, as well as ribavirin. So you need to do a pregnancy test for this patient. So now for the gastroenterologists amongst us, we have the different guidelines, the SOGIN guideline, the ISO, and the ASLD, that is the Association for the American Association for the Study of Liver Disease. So each of these societies all have their guidelines. So SOGIN hasn't really, what will I say, they've not really updated their guidelines. So the last I knew, the guideline still has the different genotypes, because you may need to go back to genotype-specific treatment, especially when you have treatment failure in such patients. Then it's also important that patients who ab initio had cirrhosis, because cirrhosis in itself is a pre-malignant condition. So despite achieving cure in these patients, you should still follow them up because they can still develop hepatocellular carcinoma. So guidelines state that every 6 months they should have an alpha-fetoprotein as well as an ultrasound scan done, and then we'll need to manage for other parameters. Then also to have, as I earlier said, you could have co-infection with other viruses and they must be managed accordingly. So usually when hepatitis C is, you have a co-infection with hepatitis B, hepatitis B tends to take a back seat. So most people will tend to treat the hepatitis C and after that will now treat the hepatitis B. Then for the HIV, you need to treat that alongside because in mothers who have hepatitis, the co-infection is easier to transmit to the baby. And then we don't give hepatitis C treatment in pregnancy, because most of the drugs are teratogenic. So that's where the little I can contribute. Thank you.
Thank you, ma'am.
Thank you so much, ma. That was quite extensive. Thank you so much. You made it so easy. Thank you so much. We appreciate you, ma. Dr. Ekele. Dr. Omo, you can go ahead.
Good morning, ma. Thank you very much for the opportunity, and thank you, Dr. Cookie. I just have a few questions arising from Dr. Cookie's explanations. I just wanted to know the place of the antivirals in patients that are in acute liver failure, and also in patients that have already had malignant transformation. Can they still be used?
So usually in patients with acute liver failure, we tend to manage them conservatively. So depending on the how the patient presents, because mostly they will present with the jaundice and then hepatic encephalopathy. So you need to manage all that. And if they're unconscious, you need to manage that. And then if they come present in shock, you need to manage all that. So it's when the patient, has recovered to an extent, then you can introduce your DAs in those patients. Then for those who already have malignant transformation, the management of HCC is different. So there we now have to stage this patient, using the different criteria that we have, to stage this patient, and so to know at what stage the patient is presenting. So we would now the BCLC, that is the Barcelona Clinic liver cancer classification. That is the commonest. We have several others, but that's the one that is one we use a lot. That stages the patient from A to D. D being that this patient is terminal and you need to just offer palliative care. But for the stage, the very early stage, that's if they just have a single nodule, you can offer them a partial hepatectomy. But if they already have, based on the Milan criteria, they have a single nodule less than 5 centimeters or 2 to 3 nodules each, not more than 3 centimeters, you can offer a liver transplant, provided there's no portal vein invasion and there's no portal hypertension. You can offer them a liver transplant. But for those who already have portal vein invasion, and even though in their early stages, and then the performance status is still good, in these patients, you can offer them some form of intervention. So this is where the interventional radiologists will come in. So they can either do a radio frequency ablation of the tumor, or a chemoembolization of the tumor. That's a TIS, transarterial chemoembolization of the tumor. Then for those who already have multiple nodules and there's already portal vein invasion, but their performance status is still fair. So those ones are within the stage C, and those are the ones that will give chemotherapy to, in the form of the sorafenib, or you can use one of the newest in them, which is the immune therapy that we use. That's is sold as, the name has escaped me. I'll remember it. So is a form of immune therapy that we use now for patients in stage C. That's for patients that have developed HCC. So when they've developed HCC, you're no longer talking about cure anymore, and the DAs would do little or nothing in such patients. So you have to manage as hepatocellular carcinoma, so of which the treatment is multidisciplinary. So so if the patient either needs a liver transplant or a partial hepatectomy, of course the general surgeons would be involved in that. And then if they need the targeted chemotherapy, where the interventional radiologists are there, and then the oncologists for the chemotherapy, and then of course you now have for the palliative care. So
Hello,
all of them are answered.
hello.
Thank you. Can you hear me?
Yes, Chief, I heard you. Thank you so much, man. I'm just wondering, for those that now survive, if they've had a cancer and they survive, don't they still need to maybe eradicate the Hep C, at least go for a sustained virologic remission? Or usually treatments of the cancers will take care of that?
And so that's what I'm saying now. It depending on because if you are painting this scenario, then you are painting that of the early, you caught the cancer at a very early stage. So because for HCC now, if you do a partial hepatectomy, so partial hepatectomy and liver transplants are the treatment modalities that offer the highest chance of a cure. And in such patients, if you meet them in that stage, you can actually still give them. So after doing that treatment modality, you can still go ahead and treat them for HCC, because it's even said that it's a patient with HCC now in the field of transplantation, they can actually still donate their organs, because of how potent the DAs are. So they can even still donate their kidney to somebody else, and the person will now be on DAs to prevent transmission of the virus. Yes, so it's supposed to be a nicer virus than hepatitis B to get, because it does not invade the patient's genome, which hepatitis B does. So that's why it's curable. Yeah.
Thank you so much, ma.
You're welcome.
Hello, thank you so much, ma. Thank you so much. Okay, can I please let's move to the next question, please?
All right, thank you, ma.
Thank you, ma.
Doctor, please, can someone help?
Master.
Okay, Dr. Biko, help us share the slide.
Okay, Chief. Okay.
You need the master. You have the master.
Please mute. Dr. Fred, okay. Dr. Jamila.
Okay. Good morning, our teachers. Good morning, colleagues. Sorry, I wasn't able to respond when I was called earlier on. Something came up. I'm going to be taking the question number 1 that was posted initially in the group under the following outline. Can we go to the next slide, Dr. Bimpe? So these are the learning objectives. Introduction, next slide. So we need to know the definitions of terms, starting with poison. So a poison is a toxin that can be solid, liquid, or gas that gets into the body by inhaling, swallowing, or absorption through the skin. And poisoning is injury or death, or a dose-related adverse effect that occurs by swallowing, inhaling, or touching these poisons. Now the epidemiology. According to the WHO, there are about 2 to 3 million cases annually of unintentional poisoning, and 1 million of such cases are severe poisonings, with 20,000 deaths that occur annually, while unintentional poisons occurs in 2 million people, with associated 200,000 suicides. Another study in Ethiopia reports the age of those that occur this that perform this poisoning to be below 30 years of age, and organophosphate was reported as the commonest poison ingested. In another Nigerian study, they reported the mean age of poisoning to be 28.53 plus or minus 13.47, with a male to female ratio of 1 to 1.11. They also reported organophosphate poisoning being the most common poisoning occurring in these patients. Next slide. The types and classification of poisons. So this poisoning can be acute or chronic poisoning, accidental or intentional, suicidal or homicidal, local or systemic. However, it usually does not occur as a single entity, but rather a combination of different types. And acute poisoning can be intentional or suicidal and can be local or systemic. So it's generally a combination of all the different types of poisoning. Accidental poisons usually occur with medications. Sorry. Accidental poisons usually occur with medications, and then the intentional is usually secondary to suicide or substance abuse. As I mentioned earlier on, they can be local, that affects the skin, the eyes, or the lungs, or even focal parts of the body, such as the legs, as in case of a snake bite without envenomation, or they can be systemic. It all depends on the route of exposure to the chemical or to the poison. And this helps in differentiating the severity of the poisoning. Now, going to the principles of management. Dr. Bimpe, next slide. Okay. So the general approach to a poison patient includes: 1, we have to stabilize the patient using the ABC of resuscitation. We take brief history, examine briefly, and take some samples for urgent evaluation. And then we decontaminate the GI tracts, the skin, or the eyes, depending on the site of the poison, the site of the body the poison touch. And then we administer an antidote depending on the type of poison also. And then after administration of antidote, we try to eliminate the poison from the system, because the antidote only prevents the poison from harming the patient. So we try to eliminate the antidote poison complex from the system. Other things we do are symptomatic management, because this poison have already incited some ongoing symptoms in the patient's body. So we have to manage these symptoms. And then the nursing care, and then psychiatric evaluation, especially in patients with suicidal or intentional poisonings. Now taking stabilization. Stabilization, as I mentioned, we take the ABCs of resuscitation, which are in the stabilization, but generally principles of management of poisoning is A, B, C, D, E, F, G of resuscitation. And then we take brief history in stabilization stage, we examine briefly. And when we examine with our eyes, with our hands, with our nose. When it comes to poisoning, we briefly investigate, as I mentioned earlier on. So next slide, Dr. Bimpe. When the patient comes and you look at the airway, the breathing, the circulation, as I mentioned earlier on. So after resuscitating, that is looking at the airway, we remove whatever is obstructing. And when the some of the poisons are still there in the GI tract or in the eye, we try to remove it. We supplement oxygen, especially when it comes to carbon monoxide poisoning and circulation. When the poison causes hypotension, we can try as much as possible to resuscitate with IV fluids. And then next slide, Dr. Bimper. When it comes to taking history, we try to take history as brief as possible so that we identify the specific poison, the nature of poisonous substance, the degree of exposure, and the time since the exposure to the poison, because that will determine what we do next. And then the history should not only be taken from the patient, however, relatives, friends, and people that witnessed the event can all be questioned. And we try as much as possible to get the sample of the poisonous substance and its relative container so that we treat it accurately. So, and examination of suspected toxic substance or material is quite crucial. When it comes to examination, Dr. Bimpe, next slide. It is powerful. We try to briefly examine for, as I mentioned earlier, on any sign or symptom of cardiac affectation, neurological, or gastrointestinal. And then after the resuscitation, we can then go on to perform, after its stabilization, we can go and perform a detailed physical examination. And this initial examination is critical because it assists in determining the etiology, but may also help to assess the severity of the poisoning in the patient. So urgent investigations we can do by the bedside include a random blood glucose, 20 minutes whole blood clotting time, as in case of snake envenomation, electrolytes, urea, and creatinine. And then we can immediately take sample for urine toxicology screening. And then later, after stabilizing the patient, we can require urgent radiographical evaluation where we can see opaque material in the gastrointestinal tract, depending on the cause of poisoning, electrocardiography, because some people might come with dysrhythmia, arrhythmias, serum lactate, arterial blood gases, and ketones. Next, after stabilizing the patient, the next thing we do is decontaminate the patient. That is removal of patient from substance or substance from patient. So in the environment, we try to remove the patient from the substance of toxic substance as early as possible. If it is carbon monoxide, we try to remove the patient from the compound. In chronic exposure of mercury, arsenic, we try to remove the person from that source of contact. And the removal of substance from the patient is what we usually do in the hospital by removing contaminated clothing. We remove toxins outside the body, that is in the eyes, on the skin. We wash it away using soap and water. And then we try to decrease absorption from the GI tract by removing it from the stomach via the mouth, rectum, or vagina. We can also flush it mechanically or use binders in the GI tract. So how do we remove from the stomach? These substances can be liquid. In such cases, we can remove manually, or we can scoop, we can irrigate. In case of solid poison, such as drug packs and pills, we can also remove them manually from wherever they are, either in the mouth, rectum, or whatsoever, under direct visualization. And then these toxins can be flushed using either emesis, gastric lavage, catharsis, whole bowel irrigation, and by the use of activated charcoal. So emesis is induced by use of serum of ipecac, and it's contraindicated when the poison is already an emetic poison, when a patient is convulsing, when the patient is in coma, in extremes of ages, when the patient is pregnant, or when there is a time lapse of more than 6 hours. There is no point in inducing emesis. So next mechanism is by gastric lavage, where a tube is inserted, is either orogastric or nasogastric tube, and fluid is instilled. The fluids include warm water, saline, oxidized solutions, sodium thiosulfate, and desferoxamine, as in case of iron poisoning. Sorry for the typo. Catharsis are substances like magnesium citrate, magnesium sulfate, and sorbitol that accelerate purification or by softening feces. So they are usually combined with activated charcoal because this only the substances only accelerate defecation, but however they do not prevent absorption of those toxins from the GI tract. So when activated charcoal is given, it burns these toxins, and then the catharsis accelerate defecation or elimination of the poisonous substances. However, they are contraindicated in renal failure and gastrointestinal tract obstruction. Whole bowel irrigation is by using polyethylene glycol, and usually 2 liters is given by mouth or GI tube. And in children, 50 to 250 mils per kg of the polyethylene glycol is given, and rectal effluent is collected. The next slide, we can see how it is given. A patient is seated where on a chair where we can collect the effluent, and the tube is connected via the mouth, and then a 2-liter bag is used to instill the fluid in the patient. So how do we bind the toxins in the gastrointestinal tract? Is usually by giving activated charcoal or burnt bread in cases where activated charcoal is not available. It has comparable or greater efficacy, has fewer contraindications and complications, and is less evasive and invasive than emetics and gastric lavage. So activated charcoal is given in a suspension of water, and it's given orally using a straw or small bone nasogastric tube. And the dose is usually 1 gram per kg or 50 grams in an adult. So as I mentioned earlier on, it binds to the toxins and then it's excreted. After a decontamination, the next step is we give antidotes, which are specific to the poison. These antidotes can be mechanical or physical, chemical, physiological, serological, as in case of envenomation of snake poisons, and they can be universal antidotes or combination. So the antidotes mechanism of actions include forming an inert complexes with the poison, accelerating detoxification of the poison, reducing the rate of conversion of the poison to a more toxic compound, competing with poison for essential receptor sites, and then blocking essential receptors on which these toxins function, or some bypass the effect of the poison. So the next, sorry, okay, the next slide is going to be, we can go through each one. We have the slides. They are intoxication in some substances with their clinical presentation, and the antidotes we usually give in case of such poisonings. So after that, we try to eliminate the poison from the GI tract or from the system by alkalinization, phosphodiuresis, and dialysis. The next slide, Dr. Bimpe, is just a schema on how we eliminate the poisons from the system. And the last but not the least is symptomatic and nursing care. As I mentioned earlier on, patient might come with respiratory compromise, cardiovascular, CNS, and renal failure. So all this need to be tackled. For in cases of respiratory compromise, we try as much as possible to intubate and mechanically ventilate such patients. Dr. Bimpe, next slide, I think. Hello? Thank you. We try to intubate using endotracheal intubation and mechanically ventilate. And then in patients that come with cardiovascular compromise, they can come with hypotension. So we try to give expanders, volume expanders, or we give norepinephrine and epinephrine or high doses of dopamine when the volume expanders do not work. And in patients that come with seizure, we usually treat them by giving anti-seizure medications. And one of the commonest example of drug that comes with seizure is INH isoniazid. So after treating the seizure, we give pyridoxine, which is vitamin B6 supplementation. Next slide. Other drugs that present with seizures include the TCAs, where we give sodium bicarbonate, organophosphates, we give midazolam, pyridoxine, and atropine, and then thiophyllene, cocaine, or other sympathomimetics, alcohol, they all present with seizures, and we treat them by giving benzodiazepines. Next slide. So last but not the least is psychiatric care. In patients with intentional or suicidal poisoning, they need psychiatric evaluation. And patients who have attempted suicide require continuous observation and measures to prevent self-injurious activities until they are no longer suicidal. Last is prevention. We prevent recurrence of such, especially in young children and confused patients. In young children, we try to prevent them from having contact with poisonous substances. In confused patients, that need assistance, we allow relatives to administer their drugs. And errors in dosing by healthcare providers may require educational effort, and patients should be advised to avoid circumstances that can result in chemical exposure or poisoning, as in wearing of boots to prevent snake bites. So the best approach to young children, as I mentioned earlier on, is try as much as possible to prevent them from coming in contact with the poisonous substances. So depressed or psychotic patients should undergo psychiatric assessment, disposition, and follow-up. They should be given prescriptions for a limited supply of drugs with a limited number of pitfalls, and should be monitored for compliance and response to therapy. Thank you. The last slide is my references. Thanks to Dr. Chinedu, because I used some of his slides and ENL's protocol. Thank you all.
Well, thank you so much, Dr. Jamila, for that beautiful presentation. Very lucid and extensive. So take comments and questions from the participants first. Then our teachers will come in. And let's keep the thanks coming on the chat. Okay, Dr. Justice, please go ahead.
Okay, thank you very much again, teachers and colleagues, and thank you so much for a very, very beautiful presentation. I just want to add a few things. One of them is when it comes to the management, it's always good to remember that they present in a pre-toxic phase, toxic phase, or resolution phase. The pre-toxic is when you evaluate, there's a history suggestive, but you really cannot find any clinical manifestation that may suggest the poison. It could mean that whatever they may have ingested was probably not in a sufficient amount dose to cause symptoms, or it could be that whatever they ingested is not poisonous, or it could also be that it's a toxic time bomb. Toxic time bomb for poisons that actually have a long latent period where they like drugs that have a long half-life before they eventually manifest. So the point of that one is that even though they appear normal on evaluation, you should still keep them for at least 24 to 48 hours in case the toxic time bomb, and then before you consider discharge. And then the goals of management in the pre-toxic phase, that's why we talk about predominantly decontamination, trying to remove what is in the gut to make sure they are not absorbed. Then the toxic phase is when they already have symptoms, and at that point, you're doing both antidote therapy and then the residual decontamination of what's left. While in the resolution phase, that's really where you want to focus on the complications and then do a lot of counseling, prevention of others. Then another thing that we must also remember to talk about is the concept of toxidromes, where a patient is probably brought in unconscious and you're not really able to get much of the history of what may have occurred, where the toxidromes are, you have the stimulated syndrome or state, where, or more like clinical state, where you're thinking of drugs that actually cause more stimulation, like amphetamines. They are usually hypertensive, opiates are usually constricted, I'll confirm that part. And then heart rate is really elevated, respiratory rate not much affected. You have the depressed state, which is usually caused by things like opioids, that usually give you the opioid state, pinpoint pupils, bradycardia in some cases, respiratory depression. You could have the normal state, in which case, just like I mentioned earlier, is the a case of the normal physiologic state, where it could also be a toxic time bomb. And then you could have the mixed state in conditions where they are actually taking different kinds of poisons, or some of the poisons that actually give us different. Please let us also look at all those on the different drugs across different states. I think I also post that on the page after this discussion. The one more thing to always add in our prevention, which is what we always tell our patients and the really particularly for children, is avoid making sure that you don't put poisons in containers that are attractive, like putting poisons in Coke bottle, Fanta bottle that might attract the children. Thank you very much.
Thank you so much, Dr. Justice, for that beautiful add-on. Thank you in advance for the material I'm going to send. And I don't know if others have materials on poisoning of different substances. Please also send to the group. Thank you so much. Okay, I can't see any other hands up and no comments on the chat. Thank you so much, Dr. Jamila. I'll hand over to our teachers now because our time is up.
Yes,
Christabel.
thank you, Dr. Akade. Thank you, Dr. Jamila. Thank you. I appreciate you. Thank you. So Justice, thank you once again for coming in. I appreciate your comments. Thank you so much. It's past 8, so we have to close this